And then, of course, I use the forceps snare polypectomy. That's how we take them out, forceps or snare. So here's a forceps polypectomy. Now here's our little polyp that I showed you earlier. Okay, so I've got this little instrument that goes down into the through the colonoscope, and I grab that polyp with that little forceps, little pinchers. That is hooked up. Oh, we don't have the cautery unit here. That's hooked up to the forceps is hooked up to a unit we call cautery. It's electrocautery. And so I press a little button. I send a little bit of electricity. It does a touch of electricity, and you see it's turning white here. So I'm burning the base, because if I just pull the polyp off, we're going to have bleeding. So we have to cauterize. And we're done. We're left with this little wound. Now you can see why I like to do the little guys, because the divot is smaller. Because here's the snare polypectomy. So here's our big guy we saw earlier. And that little tube has my snare in it. So here's a picture of the little wire. If you can see the wire right there, I put it right around the polyp. You have to practice this too, by the way. I'm real good at those you know where you get the stuff out of the vending machines with the little buckets. They won't let me play that anymore at the carnivals. Pooh. Anyway, so then we squeeze it tight. I have an assistant called Shelly. This is her favorite part, grabbing the polyp. And I constrict the bottom of that polyp, getting the whole works in there, electrocauterize, just like we did with the forceps. And when we're done, that's what's left. Oh, a divot, a bigger divot, isn't it? And 99% of the time that heals up just fine. The only other way to remove polyps is to do surgery, where you actually take the patient to surgery, open up the bowel, cut out that section of bowel, and sew the bowel back together again, which is a lot more to go through. So, there's risks, aren't they? This is surgery. You have discomfort. Colons do not like to be stretched. The only pain receptor our colons have is to stretch. All the cautery, poking, cutting, you don't feel it. You wouldn't need any sedation if that's all we had to do. But remember the length of that colonoscope. We don't like that. So we have to give sedation. So let's talk a little bit about sedation. It's generally quite safe, but it's very unique for every patient. And in fact, it's unique for every time. You may not need the same dose from year to year, and every patient needs their own specific dose of medication. So I give it myself. I start off with a small amount, watch, give a little more. We call that titration. And we have antidotes for the sedation in case we get a little bit too much. I have a rule in my endoscopy suite: breathing is important. That's my rule. And people have got to continue breathing. It's just a thing I have. I'm a little narrow-minded about it. So we do watch that very carefully. And that's why you're all hooked up to a monitor. We watch your oxygen, we watch your breathing, we watch your blood pressure, we watch your heart rate, so we know that you're safe. Now, some people can have an allergic reaction to medication. I have never experienced this in my 19,000 doses plus. I've never seen an actual true allergic reaction to the medication, but it's always possible. Nausea and vomiting, the sedation, for some people are sensitive and they will get sick afterwards. Now, if I know it ahead of time that people get sick on sedation, you know, sometimes people have other surgeries, you know, they say, gee, every time I go to anesthesia, I throw up. There's a medication I can give ahead of time. Helps a lot. It's not perfect, but it helps a lot. Okay, you can have a reaction to the IV site. You get a little inflammation, maybe, irritation. We talked about the breathing, the low blood pressure, depressed breathing. We overdo it. Very rarely I've got a person who doesn't really go to sleep, but yet they stop breathing. That's a little bit of a pickle. So what I do in that case, I call the nurse anesthetist to come help me. so we can have monitored anesthesia care. That solves the problem. It's just more detailed than I can't do the procedure and do that at the same time, so I get help. Okay, now bleeding. Well, sure, especially if I cut out a polyp. But if we just do a colon examination, whether we're without polypectomy, it's around 1 out of 1,000. If the polyp is huge, you might think maybe 1 in 400. If you just look at the colon, it's probably 1 in 2,000. So it's not a big thing. It probably would happen within 2 to 7 days after colonoscopy. I've had some happen right away, but usually it's later. I've had a few people that eat popcorn at 10 days and they scrape off the scab and they bleed, even though I told them not to. Usually it heals on its own. A lot of people may even have a little bit of a bleeding. They don't even realize it. So even out of that 1 out of 1,000, there's probably some people that we don't even realize it. But even if they have to come into the hospital and be monitored, what I normally would do is have the person come into the hospital, we would clear out the colon again, get the abrasive material, stool, away from the polypectomy site, and most of the time it heals on its own. Very rarely do I have to go back and cauterize, but I can. I can go back in and just touch it up and stop the bleeding. Now, perforation, that's the one I don't like. None of us like it, but it happens. It happens even in the best endoscopist. It will happen once in a while. If we just do a colon examination, it happens once out of 3,450 times. Out of 19,000 examinations, which would be about 12,000 colonoscopies, just doing an examination has happened to me maybe once or twice. My most strange complication was an older gentleman whose spleen cracked a little bit while I did the examination. None of us can figure that out. I researched the literature in the United States that has happened maybe once or twice in the entire country per year. So strange things happen. Many of the perforations are quite small and healing. Oh, we don't even know. Maybe they have a little bit of discomfort and pain. It seals up on its own and we don't even realize that it's a perforation. The larger ones, you can't miss it. You would know something's wrong. And normally the bigger perforation we know immediately. And we have to do surgery to close it up. Those are pretty unusual. Like it says here, after polyps, maybe 1 out of 600 polypectomies. It might not even be that often. So sometimes, thinking about the bigger polyp, what about that one that's a ping pong ball? I may say, no dice, I'm not doing it. There's parts of the colon that are thicker and more robust and they can take it. There's other parts of the colon, like where your appendix is, it's very thin-walled. And I may say, sorry, I think that the chance of a complication is too high, and I'll call the surgeon, show it to them, and recommend surgery. Now, there are some extremely low risks. Infection. I think maybe people have read about the case south of here where AIDS was being given, or they're worried about hepatitis and things like that. So theoretically, if the scope is infected, it's a theoretical possibility you could pass infection between patients. However, it's almost unheard of if the instrument's properly handled. There's a protocol for cleaning it. There's a procedure for cleaning it. And here at this hospital, we've got the latest. It's a fancy machine. You put the thing in. It's like a dishwasher for the colonoscope, and it automatically flushes it, sterilizes it, cleans it, and it's monitored. It's cultured. It's watched. We change the solution to very, very specific and straightforward guidelines. And if we follow that, the infection rate is like ridiculously small, probably non-existent. Then there's a Post-Polypectory Syndrome, which is pretty unusual, but it does happen. The person thinks maybe they've had a perforation because it's a very rare reaction just to the electrocautery. You get fever, abdominal pain, and elevated white blood count. That's a syndrome. You would need to come be evaluated. A perforation, like I said, is not subtle. I mean, it really hurts. I mean, you can't miss it. This sort of feels like it, but we do all the tests. There's no perforation. I've run into this situation maybe 3 or 4 times in the last 20 years. It occurs to 12 hours to a few days after the procedure. Perforation is much sooner. This is later. And you just have the person rest, put them on clear liquids or maybe nothing to eat by mouth, give them IV fluids and give some antibiotics. And in a very quick, short period of time, a day or two, we're back to normal.